Welcome back to the show, Talk with your Doc. With me is Dr. Kushal Dighe, and we are talking about the ischemic heart disease or coronary artery disease. Dr. Dighe, we were mentioning about what should be done when somebody has a heart attack or heart stops functioning and has a cardiac arrest. We call 911 or do CPR.
Right.
However, if somebody has just angina, chest pain on the exertion, what are the investigations they should do to explore the possibility of heart disease?
So first and foremost, they should mention this to their family physician or a primary care physician that they're having these symptoms, and then based on that, if the family physician feels that the symptoms are really convincing, then or they are not so clear about the symptoms either, then they can do certain tests. The common test being a stress test.
Okay.
So a stress test can be just done as an exercise stress test, or if the patient is unable to exercise, they can do what we call as a % cardiolite test. Or if the family doctor feels that the symptoms are very convincing of angina and they're convinced that this patient's likelihood of having blocked artery is very high, then they may directly jump to a coronary angiography.
Last episode we talked about that somebody having 30 to 40% of coronary artery block, but can have completely normal stress test.
That's right.
Right.
Because as I said, with a 30% narrowed vessel, even with exercise, that's what we do in a stress test. We make the patient exercise to increase their cardiac workload. They will still have normal blood supply. So they can meet the demands of the heart even with a 30% narrowed artery.
Right. So somebody has angina and exertion, but now
Yes.
the stress test is negative. What should they do?
So it is unlikely though, because if somebody has angina, and that means we are thinking that the patient has at least 70% narrowed artery.
Okay.
The stress test should be positive in this patient, because we are making the same amount of physical exertion, even sometimes more than the patient does.
Okay.
And this time the patient exhibits no symptoms and there is no ECG changes, or if they do a different modality as an stress test with an imaging modality, which is a stress echocardiogram or a stress nuclear test, cardiolite test, then if there is no other symptoms, no other like signs of decreased blood supply, then that symptoms are then false.
Okay. Now you were talking about angiography. Please tell us about who can do this angiography. Which patients are eligible for the angiography?
So typically, if the patient has clear-cut symptoms of angina, then they can be directly scheduled for a coronary angiogram, because your likelihood of having coronary artery disease is high in this patient. So we've already determined that doing a test or not doing a test is not going to sway you in one way or the other. We have to go and jump and do an angiogram.
Right.
In other patients who are intermediate, they are not 100% sure about the symptoms, then you do exercise stress tests or stress tests with some imaging modality. And if that test is positive, then again, typically these patients will be scheduled for coronary angiography.
So my doctor has advised me to get coronary angiogram done. What should be the preparations to be done for the angiogram? Is it like a big procedure, or?
It's a day procedure.
Okay.
So first of all, your family doctor or the primary care physician has to refer you to a hospital.
Right.
This test can be only done in a hospital setup, not in a private like a lab or so.
It's an invasive procedure, right?
It's an invasive procedure. So we put a small catheter inside the heart, either from the artery in the hand or the artery in the groin. This catheter, like the patient gets sedation, so they don't have any pain or so.
Right.
So there's local anesthetic as well. And this catheter is put inside the heart. We inject contrast dye into the coronary arteries, and we have a camera that moves around the patient. We capture the blood flow in the coronary arteries and actually see these vessels and see for blockages.
So it's like a one-day procedure. You go in the morning, evening, you're back home.
Typically, yes.
Right? And what are the risks associated with the angiogram procedure?
So typically, if the patient has stable angina, the risk is way less than 1%.
Okay.
Typically is because of bleeding complications, because we're putting a catheter inside the artery.
Right.
Causing heart attack, stroke, very rare.
Very rare.
Allergic reaction to the contrast dye, very rare these days.
Right.
So overall, this is not a risky procedure.
Now, suppose in the angiogram you find a block, say 70 or 80%. So Do you put the stent angioplasty at the same time, or?
So there are two types of physicians who do angiograms. One which are called as invasive cardiologists,
Right.
who just do the angiogram because they're not trained in doing angioplasty. Whereas some physicians like myself who do angioplasty at the same time as well.
Right.
So if we see those patients, then we just go
Put
ahead
the
and
stent?
go ahead with the angioplasty, same sitting.
So please explain us about the stent, what it is, what material it is, and how does it work?
So for example, so when there is a narrowing in the artery, we have to put a wire inside this artery. We put a small balloon to open this artery.
Okay.
And in the past, we used to just have balloons, but those arteries would collapse back again in few days' time. So we have a stent, which is like a metal scaffold,
Okay.
to keep this blockage open, so it doesn't collapse back.
So this balloon will remove the blockage, and then you put the stent, or?
So balloon just squishes this atheroma or atherosclerosic particles in the wall of the artery.
Okay.
We don't suck these things out.
Okay. Okay. And then you put the.
Then over that we
mesh.
put a stent, which can be drug-coated stent or a bare metal stents. Usually these days, most patients will get a drug-coated stents.
What is the drug-coated stent mean?
So a stent is a foreign material. So your body reacts to any foreign material by causing more of layers of fibrous tissue deposition inside the stent. And with the bare metal stents, the stents have a risk of narrowing over time.
Right.
So in order to inhibit the cell proliferation, we have drug-coated stents that kind of inhibit the cell deposition so that the stent remains patent for a long time.
So once a stent is put in the heart, in the coronary arteries, how many years does it last, or when do we have to reevaluate with angiography again to look for?
So we don't have to reevaluate anybody with angiography again. The stents, with drug-coated stents, once they are in the body, they are in their body forever. We can't take them out.
Yeah, but what are the chances of getting re-stenosed?
So with the bare metal stents, there's about 20% chances per year of having restenosis.
Per year.
It is on average I'm talking, because again it depends on the size of the vessel. If it is a big vessel, then the chances are less. If it is a small caliber vessel, then the chances are more. But on an average, about 20%. With the drug-coated stents, it's less than 5% per year.
Okay, okay.
But the patients have to make sure they take the medications as prescribed after the procedure as well.
So after angioplasty, you have to take the medicines for whole life?
So these all patients will be on aspirin for life.
Okay.
They will be on an antiplatelet agent. It depends. If it's a stable patient with at least 6 months, if the patient has had a heart attack, then at least roughly about a year's time, and then it will be discontinued.
So after the angioplasty, one has to take aspirin for whole life. One tablet every day, or?
One tablet, 81 milligram entry-coated aspirin every day.
Right. Okay, we'll take a short break and we'll come back and finish the last part of the discussion. Thank you, Dr. Dighe.
Okay.
Please stay back and we'll come back for the next part of the show.